Welcome to the podcast, Not Your Doc Anymore. I'm your host, Daren Watts. Here we address the issues essential for your health and provide information to help you become your best advocate. We encourage empowerment through education. I cannot emphasize enough the influence of those who understand clinical practice and are in the trenches on a regular basis and have had years of experience. Here to address the topic of pediatric psychiatry is Dr. Chris Rich. Thank you so much for being on the show.
Yeah, good to be here. Good to see you, Darren.
It was awesome, Chris. I'm going to read your bio because I think it's better done for me instead of you. And I do want to leave the disclaimer that Dr. Rich is here of his own accord, but has had years of education and seen patients and is able to comment appropriately on all the topics we're going to address today. So Chris Rich is an associate professor of pediatrics at the University of Utah School of Medicine. Dr. Rich graduated from the University of Utah with a Bachelor of Arts in German and received his medical degree from the University of Utah School of Medicine. He completed his adult psychiatric residency at UC San Diego and his fellowship in child and adolescent psychiatry at the University of Utah. Dr. Rich currently works as a child psychiatrist at Primary Children's Hospital Center for Counseling and is a board-certified child and adolescent psychiatrist. Dr. Rich's clinical interests include childhood mood and anxiety disorders, ADHD treatment, early onset schizophrenia, and autism spectrum disorders. On a personal note, our families go way back, and we've had so many good memories with your wonderful family, Dr. Rich. I'm going to call you Chris as we go along. Is that okay?
That's probably easier. And we feel about you. You were a good mentor when I was in medical school.
Yeah, I think our paths first crossed when you were a medical student in obstetrics, and I think I may have been the chief resident at the time.
Yeah.
I remember, I think I was trying to stress you out one time, trying to think that you were going to deliver a baby on your own. Do you remember that?
Yeah, that's easily done to stress me out. So you did that. I think you kept coming out of the room saying, I think she's ready. I think Dr. Watts, we need you. And the nurses were laughing. And I had no clue that I think you were playing a joke. It was a good joke.
Yeah, that was a good one. One that I remember still. You probably thought this is not that funny.
Yeah. No, but I think she was fine and she was not in any distress too. You were ready to go when needed, but you knew there was a wild time. But I was convinced she was ready to go.
I love it. We're going to get going. How does your practice of psychiatry look as far as time and services? What does it look like just for our listeners?
Yeah. Like you said, I work for the University of Utah. I am here on my own accord, my own opinions. I work through the Department of Pediatrics, and they have a division of behavioral health through Primary Children's Hospital. And so I work through their outpatient services out in Taylorsville. And I do kind of a different things, frankly. I still take call. So I do weekend call occasionally on the busy acute inpatient unit. I help out there on weekends occasionally. But my day job is primarily outpatient visits with patients and families, where I do mostly medication management, kind of brief supportive therapy. And then we also have a day treatment program on this campus. And that's for little kids, grade school up through high school, who are struggling with attending school or other issues going on, maybe struggling with mental health, depression, anxiety, where it's really affected their overall functioning. And so they attend a day program where they come anywhere from like 8:30 till 3:00 in the afternoon, where they get some school services and then a lot of therapy groups, recreational therapy, like just good services, speech and language, occupational therapy. We have nurses, great therapists on staff. So it's kind of a comprehensive program to really address their needs depending on what's going on. So I work in that program a few days a week, and then I do patient care in between that.
That's great.
Yeah.
What are the main diagnoses that you're dealing with in your practice, Chris?
The most common ones, as you can imagine, there's a lot of anxiety out there right now with the youth, certainly depressive symptoms. We get some disruptive behaviors with some of the younger kids we deal with who are struggling maybe with impulse control, agitation, aggression. And then occasionally you get kind of those more rare disorders where they are showing significant mood episodes, more in that bipolar picture, or that early onset psychotic symptoms. Occasionally, it's pretty rare in children, but we do see that occasionally as well. But primarily it's more that stress, anxiety, depression, where it starts to affect their ability to want to go to school, hang out with friends, more irritable with family members. And so that's where most families come seeking help to kind of figure out like, hey, how can you support my teen or my child?
That's great. To help some providers who may be listening or parents who may be uncertain about the evaluation from a psychiatrist,
Mhm.
what tools are you utilizing to help you arrive at certain diagnoses with some confidence?
So we have, of course, the Diagnostic Statistical Manual, the DSM, that we're
Mhm.
in 5. It's essentially listing disorders that have a constellation of symptoms that make up that disorder, right? So different characteristics one might see with an anxiety disorder or depression or something like that. And so certainly I rely upon that. And then my years of experience of working with patients kind of see certain trends in behaviors and recognizing kind of the mood symptoms. So you look at that, you look at overall functioning. And also we have a great psychology team in our clinic. And oftentimes we will order
Right.
psychological testing and they can help look at cognitive functioning. So if there's concerns about learning disorders, or if they're struggling in school and you think it's just ADHD, for example, but actually maybe they have a reading or writing disorder or mathematics disorder. So there could be things that could be interfering with their education. So we certainly lean on our psychology colleagues, and then they can also help with diagnostic formulation. And for like these, maybe autism spectrum disorder or
Sure.
psychosis, different batteries they could look at that are helpful in the diagnostic process. But so I do a clinical interview. Like if someone comes in for the first time, I usually have about an hour and a half to spend with the family. And
Wow.
if it's a little kid, sometimes it's hard to interview a 7-year-old or an 8-year-old without getting very bored. So oftentimes it's observation, letting them play with toys that you may see there in the background,
Yeah.
talking to parents, getting the history and putting a lot of pieces together. Sometimes it's like a little bit of a detective. You're trying to kind of figure out kind of what started when and how it's affecting functioning. With teenagers, I'd like to spend time with them for sure, alone, to talk about how school. Oftentimes I don't even talk about whatever the reason is they're there to see me. It's more about initially just getting to know them. What are their likes, dislikes? What's school like for
Yeah.
them? What's a day look like for them in their life? What's stressful? What's good? And that helps me kind of just build a foundation of hopefully low trust that we can have a conversation and then get into the main reasons they're there and try to go through some of their symptoms and review the main criteria one might see in a depressive episode or something like that. But I feel like that kind of falls into place pretty easily. Once you get talking to the teen and the parent, you get a pretty good picture of what's going on. And then you talk about resources and what's available in terms of treatment.
That's great. So I know as adults, when I would care for patients, and I felt like as an OBGYN, I did a lot more mental health evaluations than I ever thought I would.
Yeah.
But we would use like patient health questionnaires, like the PHQ-9 questionnaire. I assume those types of tools are a little less effective for childhood psychiatry. Is that kind of what you're saying?
We still use them. And actually,
Okay.
there's an intake packet that they do fill out before. And so we do review that. We look at like a Vanderbilt questionnaire, which looks at ADHD. We look at the PHQ. We look at some other kind of anxiety screeners. We're also doing a lot of trauma screening right now. So there's this UCLA screen. It's called, I think, the Brief UCLA, where it asks about certain trauma indicators. And it's
Yeah.
a brain screen, but it identifies it really well. I mean, a large percentage of the kids we see on this campus have had trauma, and trauma can be an umbrella over a lot of symptoms when it comes to
Sure.
mood and anxiety disorders or other presenting issues. Sometimes trauma can present in a lot of different ways. So that's something that we really take seriously as well, just the different types of trauma. And some kids are not always willing to talk about it, but the screener at least just kind of gives us a direction to go if they do mention it or
That's
mark.
great.
Yeah.
It's awesome. Are there any trends in child psychiatry or behavioral patterns that you have observed recently that may have been influenced by digital or societal changes?
Well, that's a big one
What is?
because I feel like social media has had a big impact on all of us. I mean,
Mhm.
the iPhone came out in 2007. Prior to that, as you know, we had the internet, right, which was there, but it
Yeah.
wasn't in our hand. We weren't able to look at it all the time. I'm a Gen Xer, so I grew up in the 80s and 90s, and we relied on a few TV channels, and we get outside and run around and do sports and played some video games with friends, but there was a lot of in-person interaction. And I feel like since the beginning of the iPhone and then years later, over time, I think that has led to more individualism where kids are alone a lot more. They're more isolative. They're more lonely. They're describing feelings of feeling lonely and maybe missing out on things. And I think that has a lot to do with social media because everything's at their fingertips. And sometimes they don't need to go out to a party on a Friday night because they're able to connect with people digitally. They can play video games. They can still text or FaceTime or whatever it might be. And they're still interacting, but they're not having that togetherness. I think just a lot of trends have changed since social media became so prevalent with youth. And so kind of a longer, that's already a long answer, but a longer answer. There's a really good book called, I think it's called Generations by Jean Twenge. And she's a psychologist out of San Diego. And she does generational research. And she's been doing research for years, all through her undergraduate years, for like decades. They would do surveys for high school students about anxiety, depression. Do I like myself? Do I feel good about myself? Those kind of questions. Around 2011, 2012, almost every indicator of mental health and kind of psychological well-being started to tank, and the numbers worsened. So they started spiking in the wrong direction. And if you think about the iPhone in 2007, I think the data shows around 2012, most kids were on social media. Around 2009, 2010, not even everyone had an iPhone. Maybe 1 in 4 were on social media. But around 2012, like 3 out of 4 teenagers were on most of the social media platforms. And that's exactly when she saw the spike of worsening depression, anxiety, suicide rates have skyrocketed since kind of 2012 through current. So it's really interesting, kind of the correlation. And some of the other factors, of course, someone could have depression underlying like genetic reasons or trauma or just, bad circumstances that certainly can impact someone's mental health. But there seems to be a pretty strong correlation with the advent of social media and just how it's really affected a lot of ways that teenagers are functioning right now. And there are a lot of examples we could list, but so
getting back to our previous question, Chris, considering the potential impact of cell phones, how do you address that question to a new teenager? What kind of questions are you asking to get at the root of maybe their involvement with social media or their phone involvement?
You don't want to come across as the bad guy who's telling their parents to take away their phone, because I think that's their biggest fear. But I think one big indicator is sleep. And I think sleep has a huge impact on their moods, their behaviors, their ability to focus in school and do well academically. And so I usually get really deep into sleep questions with kids. You kind of say, how are you sleeping? Fine. Well, what time do you go to bed? And have your phone in your room? Or what time do you wake up? And then parents they'll battle back a little bit. You don't go to bed then, maybe you do. So it gets into this conversation. And pretty soon you start learning like, well, maybe they're up at 2 a.m. Maybe they are kind of scrolling on the phone and we're playing video games. And sometimes it takes multiple visits to find out that, like I had one case where a little 9-year-old wasn't sleeping and the parents were convinced that he was in bed all night and they wanted to try these sleep medications. And I'm like, and we tried a few and it just wasn't working. And so finally I was talking about video games and things he liked. And he started kind of just saying too much that he'll get up in the middle of the night and he'll get the iPad out that's on lock, but he figured out the passcode, gets the ice cream, gets the treats, and he's up eating. And so they looked under his bed, they found all these wrappers, candy wrappers and ice cream cartons. and so we figured out that he was just up all night. So that's kind of more like a nice, funny story. But in all honesty, like I think sleep plays a huge role in what these kids are doing at night. And also sometimes that's where they get in trouble. Like they're on these sites and pretty soon they may go down the wrong road and pretty soon it could be kind of more of a dangerous situation. So I think that's one indication is sleep and how are they using their phones appropriately. And that's a whole other discussion, which I'm not perfect on that. I've raised teenagers myself. It's hard to get older to say, don't be on your phone, because the kids who aren't on phones, they may benefit from not being on TikTok or Snapchat or Instagram, and they're not comparing as much, but they also may have a hard time connecting with their friends. And I think that's the hard part, because that's where a lot of the socialization is happening. They're texting, they're communicating the phone. If they don't have them, they feel left out. So it's this kind of back and forth where eventually they probably will get an iPhone or some sort of smartphone, and you just have to set the ground rules, get really firm about what the rules are. I think docking it in the parent's bedroom or in an open site where it's not in the room is probably the most important thing. So they're not being influenced by the phone at night, and they are getting, I think like a happiness indicator in that same book was getting 7 or more hours of sleep a night is like one of the strongest happiness indicators. Routine, getting sleep is one of the biggest things that we probably take for granted, but it really makes a difference.
That's a great answer. How does public and parental awareness affect outcomes that you've found for children dealing with mental health issues?
Well, I think it's just been more prevalent. Wouldn't you agree? I mean,
Yeah, for sure.
I've seen athletes come out and talk about it. I remember Naomi Osaka started talking more openly about anxiety she was feeling on the tennis court. You remember Simone Biles in the Olympics when she had to take a break, and part of it was getting that dizziness. But I think there was some level of maybe stress or anxieties that I think she admitted she was feeling. So I think the public awareness is good. It's out there more. I think more teenagers are willingly coming in and saying, I'm stressed, or, hey, my friend has a therapist. I might need a therapist too. Or they're talking much more about it than for sure when I was in high school. And I think what it leads to was just better intervention, early intervention. Honestly, like most of these cases come to light through their pediatrician. Pediatricians probably see most of this, and then they refer to child psychiatry when it gets a little more serious or there's more issues going on. But I think most of mental health care is probably done in primary care. And so I think that's great. And then so parents bring them to their pediatrician, and then sometimes we collaborate if there are things that we can do to help out when maybe it gets more serious. So I think just in general, it's going to bring more early awareness and then being able to do some interventions. Because if we get in early and help the first or second grader, third grader, I think it's harder when it gets to high school. Not that they can't do it, but I think sometimes it gets down the road a little bit and maybe they've been missing school for a year. Maybe they've just dropped out of school or they've been so anxious they aren't attending classes. And it's really hard to catch up. Not that you can't do it, but it's always nice when you kind of figure that out in the third or fourth grade and you kind of get in there early and try to see what we can do to help out.
Yeah. Thank you. That's a great answer. There is an ongoing debate about the amount of screen time that is appropriate for children. And I know we've talked about this a little bit, but what are your thoughts on how screen time can affect a child's emotional and cognitive development? And I know you said that you don't want to necessarily be the bad guy, but maybe sometimes as a parent, it's nice to say, hey, in your consult with your doctor, this is really the information that's out there. And you sometimes can be that source of information for a parent that really can empower them. What are your thoughts on that?
I think it's about 2 hours, right? A day. I think is what they're recommending around. I think early on, I think you want to try to keep the young kids. Sometimes you see kids in the supermarket, they're holding on to an iPad.
Yeah.
They're 5 years old. I think trying to limit screen time at that age is important. Do more hands-on activities, getting them outside, moving, doing reading, or if you're doing it, having some educational things like math game or reading game. So I think all that's appropriate use when they're younger. Every kid's going to watch some cartoons, of course, growing up, things like that. I think all that's fine. But what's tricky right now is they get into adolescence that the schools are giving them Chromebooks. A lot of the kids have their own laptops that they go to school with. And so I think they're on screens a lot more than 2 hours a day. I would just say, what's the content? And probably not all screens are created equally is what I would say. So
that's good.
If someone is FaceTiming their friend or their grandpa, great. They're on a screen, but they're doing something pro-social.
Yeah.
Some of the research that this Dr. Twangy has done is that video gaming can be pro-social. In some cases, kids can be playing with other kids. I think during the pandemic, video gaming helped some kids stay connected to friends.
Yeah, good.
TV watching has been pretty neutral on mental health, actually. It's more about sedentary lifestyle. You want to get out and move. Watching TV all day is not great. But I don't think it's really affecting the mental health as much. I think the things that we're more concerned about are when kids are comparing themselves to other people and they're getting on, I hate to name a site because I'm sure people like these sites, but like Instagram or other places where they are comparing themselves to other people. I think that's more detrimental to mental health. I think they've said about 1 to 2 hours of screen time on those types of social media sites could potentially have a negative impact on mood. So I'd be more careful about those sites where kids are looking at other people or comparing themselves, I'd be a little less concerned about friends playing Madden football together or doing something where they're together, enjoying it and having fun versus being isolated alone in a bedroom late at night, just scrolling. I think that's where it starts to impact mental health more.
That's
And
great.
that's why during the pandemic, I think the kids that were already struggling socially and all of a sudden they were now home, some parents were working, they were doing school at home. It seemed like they tended to struggle more than maybe kids that were already in a friend group or doing something at the school socially, even if though they had the break during the pandemic, they were still involved somehow in those groups that it helped them still remain social. But those that were more isolative seemed to really struggle during that time. Yeah.
Okay. It's good. Are you familiar with Jonathan Haidt's book, The Anxious Generation? He quotes Twangy. I've heard her name spoken a lot in those circles. Yeah. I know that he's a big advocate of restricting the use of cell phones, especially during the school hours.
I think most schools in Utah just adopted that, if I'm not mistaken. I think the majority of schools are not allowing cell phones in the classroom.
Yeah, I think a lot of the schools that require the teachers to enforce it has become a little more challenging. Yeah. I remember in that book, he refers to having a secure box that you actually put your phone in, entering the school, and then you get it exiting. I think that a lot of the high schools, the law was not in the classroom, but you can have it in between. So for whatever the 5 minutes in between class, you're scurrying through your cell phone.
It's a tricky situation because right now it's almost like to them, some teenagers, it's very hard to not have a cell phone to remain social with them. So I think it's just using it wisely, parents kind of knowing what the apps are, not just relying on social media to get that connection. But I think what Twangy says as well is just like together activities, whatever that might be, being together with other people, socializing, in-person activities are going to lead to probably more pro-social interactions, behaviors, and I think can be a happiness indicator as well. Whether that's music, sports. So many kids I work with are on school plays. They're on the marching band or they're in the orchestra. And all those things are great because they're just having interactions that I think are important for social development. And it's not just looking at their phone.
That's great. This isn't something I had we'd spoken about before. We're doing this right now, but you and I are sports people. We grew up doing sports. We grew up in the 70s and 80s and 90s. And I think most of my summers were either golfing or playing tennis or baseball or soccer or basketball. Right. And it's interesting because those people who develop those skills in their early years, it just becomes such an easier thing to do when you're older. Right. That neuroplasticity changes. And I don't know if you know the answer to this, but I would assume that those habits that you develop in your childhood years, even as it relates to scrolling and doing things via screen time, I would imagine sets that maybe for a lifetime. Are we seeing that? Is there any data on that?
I'm not sure the specific data. I think like the pruning that you're talking about, I think kind of the use it or lose it mentality, I think is true for probably everything we're doing. So that's why I think building those social relationships and learning how to interact with each other is so important. During the COVID pandemic, kids lost a lot of time of socialization, right? And it was hard. And so I think those kids who were sophomores, juniors in high school, when all that happened, they lost a chunk of time of that key time where you're walking down the hallway, talking to people, figuring out how do I ask this person if they want to go hang out or do something. Oh, that's really important as we get older, because then all of a sudden you have jobs and you're talking to people and you have to learn how to interact. So I think that all that pruning takes place, and whether it's playing sports or just being in a group of people and being able to socialize is really important. Now, if someone has like social anxiety or other issues, like that's totally understandable, and you work on that. And even with that comes practice, right? I think the thing that I've learned, that maybe another trend I've seen, is that sometimes that feeling of anxiety that we all feel sometimes, right? When we walk into a room and we wonder, are they looking at me? Or if I have to be an impromptu speech at a family dinner, I don't want to do that, like let alone somewhere. And so that anxiety is real. We all feel it, but the tendency to avoid, I think, is a lot stronger with the kids I work with. Like that feeling of unrest or anxiety is really hard. So that feeling of I'm not okay really gets deep inside, and it leads to that avoidant behavior where they stop socializing or they stop going to school. And I didn't think that was an option when I was growing up, that you could just not go to school. But a lot of kids, I think through COVID and doing online schooling, which by the way, online schooling can be great for some kids. I don't want to belittle that, but I think some kids just start saying, I'm not going to school today because of a test or they feel stressed. So I think,
Yeah.
the avoidant behaviors is a big step that we deal with a lot. Like some exposure is really good. Like a little bit of exposure of whatever that anxiety is can make a big difference, whether that's talking to someone or just going to school for a couple hours, then go home if you have to. But if you start avoiding too much, as you know, once you miss things for a couple of days, it's really hard to go back. And so a lot of
Yeah.
we do is getting kids back into school. That's one of the strengths of our day program that I work in, is we have great teachers and staff who get the kids back into a smaller classroom environment on our campus. They get the confidence up, they're doing well socially, academically, they're showing themselves they can do it. That's not the question. It's just maybe the environment's too big, but we're giving them a small skill and showing them, hey, you can do this. And then when school starts up again, it's really cool to see the success that they attain by building on the foundations they learned, like in a day program. So that's been really rewarding for me to see kids a couple of weeks later or a month or two later, and they're back in school and succeeding. And the teachers, wow, what happened? Where'd you go? And what happened? Because they see big changes. So that's been fun.
That's great, Chris. Awesome. We're going to switch gears just a little bit. Could you provide us an overview of the most common psychiatric medications prescribed to children and teenagers and their typical uses? That's
okay.
Just feel free to speak freely on this.
Okay. Yeah. And I know there are probably a lot of opinions about medications in children. As a child psychiatrist,
Sure.
I'd rather not prescribe, honestly, but
Yeah.
I think I have seen them really impact people in a positive way, and we do it very carefully, and we're very, very thoughtful about it. But when it comes to like traditional depression symptoms, anxiety, I'm sure people have heard of selective serotonin reuptake inhibitors, or SSRIs. I try to stay very close to medications that have been studied, that are FDA approved, that are evidence-based, that we have some data on. So most common for like depression, anxiety, I would probably say fluoxetine, which is the generic of Prozac. That is an FDA indication for depression in youth, as does Lexapro, or the generic is escitalopram. So those are two we use pretty frequently. I would say sertraline or Zoloft is very commonly prescribed as well. Those are probably the top three that we probably use for depression and anxiety symptoms. There are some other ones, duloxetine or Cymbalta. That's also FDA approved for generalized anxiety disorder. So those are probably the most common. And then when you think about ADHD, of course, everyone knows about, stimulant medications. Methylphenidate was the original Ritalin back in the 40s or 50s, whenever it was. And that was named after the man's wife. He developed the compound, and it was methylphenidate, but he called it Ritalin. I think her name was Rita. Big information. But methylphenidate is commonly used for ADHD symptoms. And then, of course, they have the other amphetamine ones called Vyvanse and Adderall, which are also prescribed. Those, again, we're very careful with. We check heights and weights at every visit. We check blood pressure, and we make adjustments depending on how they're doing. But they're very successful when they do work, and parents notice a difference quickly. In terms of mood stabilizers, there's just a whole gamut of medications out there now that are considered a mood stabilizer, but they have different mechanisms of action. You have the ones that affect dopamine that are called Abilify, Risperidol, Typine, or Seroquel. These are ones that are commonly prescribed, but they're more for severe kind of bipolar or significant mood episodes. And so those are used when someone's really struggling with agitation, aggression, or cycling mood episodes. And then those who have psychotic symptoms, kind of the same class, we use Abilify, Risperidol for those medications. I'm saying the brand name, well, that's okay, but it's easier to say than the generic sometimes. But really the most common are probably like the SSRIs and the medications we use for ADHD. And we also use non-stimulant medications as well that are not like the Adderall or methylphenidate. There's one called Strattera that promotes more norepinephrine, which is a non-stimulant for ADHD. And we have some that just help with impulse control called clonidine and guanfacine that are used for blood pressure modification for adults. So it has some effect peripherally, but centrally it seems to impact norepinephrine production and seems to be pretty helpful for impulse control. So those are kind of the main ones we use. And oftentimes we will start with therapy. We'll start having them meet with a therapist in our clinic to start with therapy first. And then if it gets to a point where it's more moderate to severe depression, anxiety, that's usually when either pediatricians or therapists reach out to us to help with.
That's great. How do you balance medication with other treatment methods such as therapy, lifestyle changes when addressing any of these mental health issues in children and in teenagers, Chris?
Yeah. So that's very important. So as I meet with someone, do that initial assessment, I go through the things that stand out. So it's like we mentioned sleep. I'll always talk about sleep, just how important getting really 8 to 10's better. I mean, seven's a kind of at the lower end. Anyone who gets
Sure.
6 or 6 is eventually going to become sleep deprived, right? And that can impact a lot of things. So I talk a lot about sleep, talk a lot about exercise, just as a baseline. Like these are things that are so important, regardless if we use a medication or not. It's good to get outside, try to move 30 minutes a day, try to get in so many steps. I mean, these watches we have now, they track all this. Might as well use
Hmm.
them in an effective way. So definitely talk a lot about lifestyle. A lot of kids don't have breakfast, I'm figuring out. A lot of teenagers
Wow.
wake up and just grab their backpack and head out to school. Then they have maybe a bag of chips for lunch. So by the time it's dinner time, they've nearly been fasting the entire day. Then they wonder why they're tired and why they can't focus. So we talk a lot about nutrition, talk a lot about making sure they're eating snacks throughout the day. If they're not going to have lunch, then get a protein bar or grab a muscle milk or some sort of chocolate milk where they're getting something. Because all these things really do impact kids. And I think they take it for granted. As adults, we know we can go 6 hours and we're hungry and we start to get sluggish, but they tend to go all day. So that's a huge part of what I emphasize at every assessment. And then for mild depression, mild anxiety, really the recommendation is like cognitive behavioral therapy. That's probably the first line treatment for a lot of these things, or learning coping strategies, learning how to cope with stress, developing some very practical things they can do at school or other settings when they're feeling anxious or depressed, like try to learn some strategies on how to deal with that. And then if it gets to the point where it's impacting their functioning, maybe how they're getting along with family, maybe irritability is increasing to the point that there's a lot of arguments at home, fighting, not wanting to go to school, impacting relationships. That's usually when they come to see me, honestly. Like a pediatrician oftentimes will start fluoxetine or sertraline for mild or moderate depression, anxiety, but they come to see me normally when there's just more functionality issues to the point that it's impacting relationships or school. And that's where medications, I think, play a big role, but you still really have to emphasize. Most studies have shown, whether it comes with ADHD, depression, anxiety, that the combination of therapeutic interventions plus a medication has the best outcome. And these are called
Okay.
like multimodal studies where they look at placebo, medication alone, therapy alone, and then the combination. And in
Hmm.
almost every case, therapy plus medication seems to be the most productive way of receiving help. Not that either one can be effective, but the two together seem to have the most support for the evidence and getting better sooner and faster.
Okay. That's awesome. Well, I don't know if we have to go through every medication, but what are some of the more common side effects and maybe even long-term implications of some of these medications in children? And
Yeah,
how can our parents or healthcare providers work together to monitor and address them?
I think one of the most common things we see with children is like at younger age ADHD. And first of all, you have to assess it really carefully, make sure that you're looking at it correctly and ruling out other things that could be impacting it. But if you settle on the diagnosis, stimulant medications are known to reduce appetite. And they've done some studies where they've lost to a centimeter to 1 to 2 centimeters a year in height. So it doesn't sound like a lot over time. They could lose an inch or two. So it's something that we track. So we track height and weight really carefully and
Interesting.
blood pressure. The dopamine nature of these medications that promote dopamine, they can sometimes impact the cardiovascular system. So blood pressure can be elevated. And sometimes if it's not the right medication or you overshoot the dose, the kid can become more irritable or reactive with their mood. So we definitely watch for kind of that irritability. But the long-term side effect would be mostly the height and weight and just making sure that they're still on the growth curve and they're tolerating the medication, especially as youngsters. When they're 16 or 17, you worry a little less about it because they've had their growth. So that's a serious one. We really track that carefully with kids who are on ADHD medications. And for depression and anxiety, really the SSRIs are pretty well tolerated. So I'll still check blood pressure and check their height and weight, but very rarely will someone have maybe some weight gain or sleep difficulty. But mostly these medications are pretty neutral when it comes with weight gain or affecting sleep or appetite. They're mostly pretty well tolerated. The mood stabilizers I mentioned, there's some common ones called risperidone, olanzapine, aripiprazole. Those are used for bipolar disorder or psychosis. Those have been around since the 90s, and they tend to impact the way we metabolize fats and sugars. So that's been a newer problem for us. The older ones like haloperidol, and they would impact dopamine and then have an inverse relationship with acetylcholine, where you get more muscle stiffness, like these extrapyramidal symptoms. But that's from the older medications. And I think we saw that with like Parkinsonian symptoms, things like that. But now we worry about like glucose and insulin resistance, almost developing an elevated hemoglobin A1C. So we're checking cholesterol, we're checking triglycerides, we're checking hemoglobin A1C on every 6 months or every year for kids that are taking these medications. So that's been really since the early to mid 90s that we've been really tracking that really closely. And there's some pretty good guidelines on that, where early on you're checking height and weight, even waist circumference in some cases. And then a few months later, check the lipids again, and then maybe 6 months after that. So we really track those parameters, and that could be a long-term issue if you don't address it. So if I see the trend going in the wrong way, we'll stop it pretty quickly and try to get on a different type of mood stabilizer that doesn't have that side effect. It's just they've been proven to be so helpful in a lot of cases. They really do help reduce agitation, aggression. They help with mood stabilization. They work on some of those symptoms of psychosis, that they're so effective that we use them, but we need to be really thoughtful on how we're using them and make sure we're following those parameters and checking height and weight, because otherwise they can sneak up on you. They put on maybe 10, 15 pounds in 4 to 6 months and you didn't find it. And so you want to really track that closely. Yeah. Those are one of the main ones. I don't use a lot of lithium lately, but lithium is a very common mood stabilizer. That's one that is metabolized through the kidney. And so you definitely want to watch their renal function. Sometimes it can be, if you get too high, too high a lithium level, it can affect the heart, thyroid. So it's interesting though, I did all that in medical school, but as a child psychiatrist, I think some people think that we're just talking to people all the time or just prescribing meds. But honestly, we're doing a lot of kind of thoughtful medication and medical monitoring, because these medications do have potentially untoward side effects. So we try to keep those skills up that we learned in med school and not just not think about it. But we have to partner with nutrition colleagues as well when it gets to a point. And in the same way, they come to us if they notice like a child's falling off the curve, and they reach out and say, hey, I know they're on Vyvanse. They've lost 3 pounds over the last 6 months. What are your thoughts? And so it's very nice when you can collaborate with colleagues. And I've enjoyed that as part of my job as well.
That's great. How can parents, Chris, make informed decisions about medications for their children, especially, and this is, I think, the challenge of just being a doctor, especially when they're faced with abundant and sometimes contradictory information online?
Yeah, I think there are some truth online, but there's a lot of stories that I'm sure are the worst case scenarios that could probably lead people in the wrong direction. But I think looking at studies, like they've got some good studies on antidepressants and anxiety, ones that have been peer reviewed, and there's ones on depression studies, anxiety, where I've talked about that kind of combination of therapy, medication. And in those studies, they will review the medication, but that's a lot to ask the parents to read a study. So I would try to have the parents talk to their pediatrician, talk to their doctor openly about side effects. And I try to be very transparent and review informed consent, review possible side effects. And so I think doing their own reading and certainly learning with the medication, but hopefully they can have a good productive discussion either with their pediatrician or someone they really trust, or their child psychiatrist, just to talk about what are the possible side effects. Because I'm really honest about what could happen and the benefit, kind of pros and cons, and go from there, but really have an informed decision. I'll talk about the neurotransmitters. I'll get really into the detail of GABA and glutamate and dopamine, and really bring up these things that these neurotransmitters do physiologically and what we're trying to accomplish by either blocking or promoting a certain chemical to help with their moods or behaviors, knowing that I know the science isn't perfect, but I think we have a lot of good data behind it. There's been some good studies. So I try to trust that and then just be honest with the parents about what their risks and benefits are.
That's great. When parents are motivated to do their own reading, is there a good place that you love to send them?
I think the ACAP website, the American Academy of Child and Adolescent Psychiatry, they have good primers for parents. They have good information, and it's written in a very kind of non-biased way. They give information about depression, anxiety. They give nice practice parameters that parents could read through. They talk about the therapies and the interventions that can be helpful. So it's a very kind of nice site, and they even have a site for parents to look at. So
That's
I think
great.
that's a place to start. And there's always good books out there, but there's just so many self-help books that you could go anywhere. That's more from a therapeutic standpoint. For medications, I would try to go to the source and make sure you're going to like a reputable site.
That's great. How have you found that children and teenagers perceive taking medications for mental health issues? And are there peer or online influences that may affect their views that you found?
I think characteristic of this Gen Z, this group of kids we're talking about, that generation, 1995 to 2012, I think is their birth time. I think they're very open about mental health. I've noticed they talk to their friends about it. They say, my friend has a therapist. I mentioned that. They talk very openly about it. So I think they seem to be willing to say, I'm not okay and I need help.
Yeah.
And that's really great. Sometimes it gets to the point where they maybe feel a little helpless with it. And so let's try to boost them up a little bit, give them more confidence. But I think online, it could be sometimes they can see so much that they start wondering, do I have this disorder? So I've had some kids coming in saying, I think I have autism. And that's pretty common these days for kids to think they have autism. And actually some say, my friend has autism. I think I want to have autism too, in a way like they're seeing that the people they know are really resilient or cool kids, and they wonder if they have similar characteristics. And that's why it's a spectrum. I say most of these disorders are spectrum.
Sure.
Like we all have features of depression, anxiety, difficulty with social relationships, but there are certain tenets of that where you want to have criteria for all of them. So I do a lot of education about that. Not everyone has everything, but they come in asking questions about that, which I think is very unique. I don't think I knew what autism was really when I was in high school. And
For sure.
you're very informative. That goes back to maybe just being online. They're exposed to a lot of information, a lot of opinions. So they come in with a lot of questions. So I found that kind of fun. And parents sometimes will come in saying, I think my child has bipolar disorder. And again, you sit down, talk to them about what that means. And it's not just having up and down moods. That can be with all of us too. And irritability can be driven by a lot of different factors. It's not just mood disorders. So I spend a lot of time just talking through some of these issues with parents and trying to bring them to a point where these little bursts of behaviors or moods don't always indicate a diagnosis necessarily.
Yeah.
It's just normal behavior for a teenager. Whatever normal is these days, I think we look for normal, and I still look for normal, which has a wide breadth. Yeah.
Have you noticed any trends or changes in the prescription of psychiatric medications for young people that might reflect maybe societal shifts or influences?
Not so much recently. I will say, I think it was back in 2004 when all antidepressants received a black box warning because of possible increased suicidal ideation, which again,
Sure.
So it was based on, I think it was Effexor, which is venlafaxine, and paroxetine or Paxil. Those were the two that they seemed to increase the risk a little bit. It was like 1% to 2%, actually. It was quite a low number. But what I found afterwards is that some primary care physicians and others and parents were concerned about prescribing SSRIs, which have been the mainstay for depression treatment. And for a brief time, the prescription rates went down. And for quite some time, suicide rates were decreasing. And during this little blip, I can look at the dates, but so there was an increase again of some suicidal behaviors. I think these medications can be very effective in helping with depression and reducing suicidal risks when used appropriately. And there was this time that because of the black box warning, people were prescribing like tricyclic antidepressants or Wellbutrin, which is an antidepressant that has more dopamine activity, but the SSRIs were being less used. So that was one trend I saw almost 20 years ago that started to impact the prescribing rates. But otherwise, I think we as child psychiatrists, like I said, we try to stay close to the trunk. I try to prescribe medications that are FDA approved and good evidence-based. And if parents come with ideas, I try to just talk about it, but I don't prescribe something if I'm not cool with it either. So
That's great. That's an awesome answer. What advice would you have for parents to help children manage anxiety and stress in today's fast-paced, often pressure-filled environment? And do you think that's worsening?
Yeah, I think we've talked about it. There's just a lot of indicators that it is very stressful. So yeah, how do you manage that? I think like these happiness indicators, like getting involved in activities where they're around people, getting enough sleep, being involved in clubs at school or organizations outside of school, whether it's sports or music, debate. A lot of kids are in debate. A lot of kids are in plays. I think getting involved in something that's bigger than them will just widen their net. And it can't just be parents. Like, you've got to have good coaches or teachers or people that child can go to as well. You need like mentors, I think, are really important. But yeah, I would say cell phones play a role. Like, honestly, like, I think putting the phone down more. I think anything that's screen related, that is more about social media and comparisons and scrolling, generally does not lead to great mental health. I think doing more activities that promote in-person connection, whatever that might be, is, I think, the trend. And I think even some kids are recognizing it. I know some kids who watch like Stranger Things or some of these shows that are on Netflix that are promote the 80s. Like, man, I wish I lived in the 80s. That was, it's like an easier time. And I'm not sure if it was or not, but they know that cell phones weren't there then. And so I think the social media is still part of that, Darren. I think you got to manage it carefully. Yeah. And again, I was not perfect as a parent, but trying to get kids to be involved in something bigger than themselves and be engaged. And some kids can get over programmed too, right? They're going from this practice to this practice, and that can be a lot too. So some downtime, like, what are their own hobbies? Like, do they have some personal hobbies, whether it's reading or art? I've got a lot of kids I work with that are great artists, and finding hobbies that are, again, showing off their skills, things like that. I think that's really important.
That's awesome. I don't know if this is true, but it seems like there's increased discussions about mental health online. And do you think, as a result of that, are there concerns about overdiagnosis or an over-reliance on medications for treating children and teens?
Yeah, I think that's part of it. Like I said, I think some people are diagnosed, they're self-diagnosing based on symptoms, and they come in and they talk about it. So I think that part of that's true. And I think medications can be used very carefully and appropriately for the right disorder, for the right issue. But I try to be pretty careful about, this person's irritable, so let's just give this mood stabilizer that might bring down this irritability, which it may. But I think it's always good to figure out, like, what's the trigger or what's the cause of whatever it is, the inattentiveness, the anxiety, the inability to sleep, the sad mood, the anger episodes. Like, we can always say, yeah, let's just put a medication on that. But I think we got to spend the time finding out, well, what is that? What's triggering that irritability, or what's triggering that anxiety about going to school? Because if you can get to the root of it, oftentimes it may just be something that can be changed. Or maybe it's a kid at school that was either not nice to him or stressed about a certain subject. There's a lot of reasons why kids struggle. And so I definitely would agree that we don't want to be over-reliant on medications. But when it comes from a biological factor, I think sometimes it can make a big difference. But there's a lot of things that are socially or psychological that may need interventions that are not medication related.
That's great, Chris. Within your system, what are the things that are available to get at the root? An hour and a half evaluation is amazing. I compliment you for that.
No,
but I assume you can't do that with every visit. I know there's psychologists, or do you have a team of people that kind of help you get at the root, helping to navigate maybe children's feelings about their mental health?
Well, for sure, like in our clinic, it's a team, and it takes a while to build a child's trust as well. So that first visit is laying a foundation and trying to figure out what's going on. And I'll tell the parents something like this may take several more months for us to figure out what's going on, just to be honest. But oftentimes the kids that I see for medication management are seen by a therapist weekly in our clinic. So they're getting to know the child, and then we try to team during the week and say, hey, I found out that he's not getting breakfast every morning, or he has to go to school to get breakfast. Mom's leaving at 5 a.m. and he's left to taking his own medication in the morning, and he's 12 years old, but he doesn't have breakfast. So these little things we find out about him. And then it's like, okay, like, what can we do to support the kids? And then, like I said, we do psychological testing. They spend an entire day or 2 days sometimes with the family, and the kid literally like almost a half a day or a whole day reviewing everything, like starting from childhood, they're already kids, but at their very young age, and then getting up to the present. So then they do the batteries. They look at their cognitive functioning. They're looking at how they learn things. Are they more a visual learner? Is it more auditory? So that's really helpful to get all that additional data. And then we try to put it together, but it can take months sometimes to do that. And sometimes it comes in, it's like, okay, this is coming together. We get the feel for it and we can move forward. But oftentimes for those that are really tricky, it takes a while. So In our day program, we have a speech and language. We have a speech therapist who will do their own assessment. We have an occupational therapist who will do their own assessment. And then we got a teacher who's with them every day, assessing how they're learning and focusing. So we'll get together often and put that information together and say, oh, okay, that makes sense. That kid's not understanding what we're saying. Like 2 or 3 words is the most they can understand. You get into a long sentence, they're not grasping what we're telling them. Then they get frustrated and they throw a tantrum in the classroom, and we're wondering why they're mad, but maybe there's a reason behind that. They're not understanding or they're getting frustrated with the learning process. So anyhow, that's just a long answer. There's so many factors that could impact someone's behavior. And so
Sure.
to do it all alone would seem overwhelming. So I'm grateful to work in a system where I have good therapists and psychologists and other team members that can help out with the diagnosis. I don't pretend to know everything by any means. I really rely on those other people to
Yeah,
help me become a better doctor, honestly. So
that's great. That's why you're a good doctor, relying on those people.
it helps.
That's great, Chris.
Darren, like you got to have teammates. Otherwise you're playing
Oh,
one.
yeah.
You got,
Makes a huge difference. Well, this last segment I refer to as the Delta segment because we are human and you are definitely a different person than I knew you 20, almost 30 years ago.
yeah.
How have you found that taking care of patients with these conditions has changed you?
Well, and I think you grow up and just even becoming a doctor was a humbling experience. Like I had to apply a couple of times to go to medical school. And I think when you go through like middle school and high school and you think you're pretty popular, you think you're pretty, pretty cool. But when you start going through the process of becoming a physician and all that hard work and then working with kids after that and see the difficulties they go through, hearing stories about being abused, traumatized, bullied, it just really makes you think about how we treat each other in the world and how kindness really matters. Just a simple, kind word to a student or someone can make a huge difference. I'm much more sensitive, I think, to other people's feelings to the point that I probably tear up more than I used to when I was a young adult and recognize suffering in other people. And it can be hard. I did find though, Darren, like in medical school, I took the physical illness of a child home a lot harder than the mental illness for some reason. When I saw a sick
Really?
child, I really struggled on some of those pediatric rotations, but being able to be vulnerable with kids, and I share bits and pieces about myself just to let them know who I am. I don't get into all great detail, but I mentioned that I've raised kids and I've had a family, and I think that helps me connect with them in a way that maybe they can trust me. So I don't know. I just feel like I've learned a lot. It's a privilege to work with children. Part of adolescence is this risk taking. Like they're doing hard things. They're doing things that stress people out. Like parents are stressed when they have teenagers. And I've learned to really appreciate the adolescent years. That is a time of growth and courage and confidence. And if we squash that too much and don't let them do it, then it can really alter their trajectory. So trying to build kids up and let them know that, hey, like you can do this and you're awesome. And yeah, you've had a rough year, but you can do this. You can catch up on school. You can graduate, and instilling that confidence. I think that I've loved seeing kids that I started working with in elementary school and how they've graduated from high school. I've been here long enough now to do that, where I've seen that trajectory, and it's just been a super really enlightening experience. And then there've been hard times too when kids have died by suicide, and it's been really hard to see that. So I think I've just become hopefully a better physician and more empathetic and aware of people's suffering, and try to hopefully do something about it, but also recognize that I'm not perfect either. And when I make mistakes, I got to own it as well.
Yeah. That's awesome. Well, it is amazing. I think we're in this unique situation where you see what people go through. You see the sacrifices people make to get where they are. It can't help but change you.
I'm curious about you. How about you? I'd like to hear because I know you were a great mentor to me, and you were always that compassionate, kind doctor that I think I wanted to be. So,
well, you're so nice to say that. And I think you develop a greater compassion as there's just no question. You see people's suffering. No, I had a unique situation because I was an obstetrician and I was able to see people go through labor, and there was never a moment that I didn't appreciate the power of labor and what people went through. I was so often amazed of what people could endure
Yeah.
And so I think that changed me. It definitely made me a softer person and more appreciative of the goodness of people. I felt like that's what changed me.
Yeah.
Well, this last question, Chris, is this. I know that people that possess real knowledge of the current medical system are those that work within the system, like yourself. If you could fix what I think we're hearing a lot of people talk about, the broken healthcare system, what steps would you want to make to change the delivery of healthcare to your patients? And while you're thinking about that, I definitely feel like your system of being able to create a day system to see and evaluate and be with patients sounds like a great thing you're doing. So if you could change something, what would you want to do?
Oh, it's hard. I work in a pretty good system. I will say that. I think insurance still plays a difficult role. Like sometimes, like one thing that frustrates me is when we bring someone into our program and they come in for a particular reason, maybe avoidance of school, and then they start coming every day and they're doing well and they're enjoying it and we're seeing progress. And I'm documenting that in my notes. Pretty soon it's like, well, they don't need to be here anymore because they're doing so well. That's why they're here. And that's why they're doing well, because the team is so supportive and they haven't quite maybe reached those goals. But after, maybe they're being discharged after 4 weeks when it's a 8 to 10 week program, for example. That's frustrating. And so that happens. But I think like insurance in general, like there are certain insurances we don't take. And I think when it comes to like broader things like mental health, which is just affecting everybody, I wish there could be a way that programs can contract with all the insurances, whatever it is that's needed. But when it comes to like mental health issues, like we got to get them seen. I don't know how many million, like I was looking at stat, like there's like 74 million under 18-year-olds. And so when it gets to the point of trying to see a specialist, we got to find a way to get them in there sooner and cut down the red tape. Because there's just not a lot. And they're great nurse practitioners, a lot of great people who do other mental health, but in terms of the most experienced, the most well-trained physicians out there, child psychiatrists to deal with mental health, there's only a little over 11,000 in the country. And so I think we just need to find a way to get these kids to these providers in a way that they're seen quickly. So access is a big thing we try to focus on in our program. How do we increase access? How do we reduce red tape and get them seen sooner for therapy and medication? But I am grateful to work for a system though, where I don't have to worry about that very much. I try to just have my schedule open. I'll see who I can see. And if they're there, I'll see them. Doesn't matter to me what insurance it is, but I know that's the reality where things are sometimes. So I just try to be available to see kids when they're in my schedule and just do the best I can.
That's great. That's so good. I'm just going to leave this final charge to our listeners to help to use this knowledge to go forward and improve your health. Seek out a healthcare provider that can get you the most appropriate level of care, like the good Dr. Rich. If you are a healthcare provider, go forward with greater knowledge to deliver the best healthcare in one of the most vulnerable and essential interactions with those who are entrusted to your care. And we just need to clarify that the medical advice and procedures do not substitute for your own professional medical consultation. In addition, listeners or viewers need to be aware of the limitations of the information provided generally. And you may want to know this, that others want to know that you can find this on Apple Podcasts, Spotify, Amazon Music, and YouTube at Not Your Doc Anymore. And you can also find us on Instagram at DocWatts_. So thanks. And thanks to all those that made this possible. Thanks, Chris. You're a good man.
Yeah, appreciate it. Thanks for having me.
Hey, it's good information.